We are going to be talking today about the treatment of cutaneous manifestations in systemic lupus erythematosus. I have disclosures due to the fact that there is interest in the skin in cutaneous lupus, and I was involved with developing the CLASI, which is being used in many lupus studies internationally. We will talk about epidemiology, topical approaches, sun protection, use of antimalarials for skin, immunosuppressives and thalidomide and derivatives, and finish talking about some of the newer biologics that are being studied. First, to say that quality of life is very important to patients with cutaneous lupus, and you can see in blue here that the higher the score, the worse. That patients who have cutaneous lupus have a very high score on a disease index called the Skindex score, looking at the emotional realm in particular. So patients are terrifically impacted by cutaneous lupus. Most therapeutic trials are for SLE, and CLE patients are excluded from most trials, although the histology is really quite similar to SLE with skin involvement. Some SLE patients with skin-predominant lesions are ANA negative, and that's another exclusion for trials. And then there's a need to stratify subsets of CLE as we start to think about how SLE therapeutic trials are evaluating effects in skin. There was a community panel that was published in terms of recommendations in the Lupus Science and Medicine last year. And one of the recommendations was that if skin improvement is strong enough when nested in an SLE trial, then treatment should be made available for patients with CLE, whether or not they meet classification for SLE. There are several validated disease severity tools for different organs, and organ-specific measures are important. They provide the potential for clinical and translational studies, and many new treatments targets are evolving, and the opportunities are amazing. However, the disease is heterogeneous, and we need to do a lot of studies related to disease pathogenesis. We have the CLASI now, which is validated and looks at activity from the standpoint of erythema, scale hypertrophy, and non-scarring alopecia, and damage based on dyspigmentation, scarring, and scarring alopecia. This was initially published nearly 15 years ago, and is the basis, again, for many of the studies in skin. It's a one-page instrument that measures on the left-hand side activity and on the right damage, and you end up on the left at the bottom of the instrument with an activity score, and on the right with a damage score, where there's been a lot of validation studies, and many of the studies I'm going to be presenting have used this instrument. We know that when you categorize a patient as having mild, moderate, or severe disease based on the CLASI, that you can tell that patients, for instance, with severe disease have very high scores, which means bad quality of life in the emotional realm. But also with increasing severity of their skin activity, you can see an increase in symptoms as well as functioning in terms of the impact on quality of life. And overall, we've been able to show that activity is often affecting patients more than damage, and thus therapies that can intervene with activity can be helpful. So there are about 10% of patients that we've characterized in our group as being refractory to disease. And refractoriness would mean not responding to antimalarials, immunosuppressives, and in some cases, thalidomide. And so it's important that we develop new treatments for those patients, but in particular, potentially for patients who have need for immunosuppressives based on their skin, but maybe there could be safer therapies long term. We know smoking aggravates lupus and causes problems with cutaneous lupus refractoriness to therapy. And here you can see the patients that we defined as refractory were much more frequently smokers, almost 75% of them, relative to the non-refractory patients that only were about 20% smokers. So clearly smoking is a risk factor, and in terms of therapy, one of the most important things initially is to get the patients, if you can, to stop smoking. There have been guidelines in Europe that have been released, and we'll be talking about many of the therapies that are on these recommendations. The treatment initially is heat avoidance, which can also aggravate the disease, avoidance of drugs, particularly in patients with subacute cutaneous lupus that could be triggering the disease, things like thiazides, TNF blockers, and many other drugs. Sunscreen use is very important, and certainly patients are not as compliant as they need to be. But we recommend a high SPF, 70 or higher, mainly because patients are often so photosensitive that lower SPFs are not going to be as effective. Often we recommend combining with Mexeril or Helioplex, which are more UVA long wavelength blockers. And physical blockers also can be quite helpful with titanium or zinc oxide. If patients are compliant with their sunscreens, then it's also good to supplement with vitamin D. And sun protective clothing such as can be very helpful, as well as sun avoidance and hats. The treatment of cutaneous lupus includes use of topical steroids, and we'll talk more in detail about this. Topical non-steroidal T-cell inhibitors, including tacrolimus and pimecrolimus, and these can be effective most frequently as adjunctive therapy. Often the patients require systemic therapy, but then adjunctive use for these topicals, unless they have mild disease, in which case the topicals alone can work. And then intralesional steroids can be helpful for individual lesions or if there's scalp involvement, because you can direct steroids deeper into the skin. We know that compliance with topicals in cutaneous lupus is not very good, and here you can see a fall off very rapidly over time because patients have a hard time applying things for long periods of time on their skin. That brings me to talking about the different classes of topical steroids, and they go from class 1 to class 6. Class 1 is the most potent, and it's important, I think, to look at charts of potency of steroids, because you want to use the right potency of steroid in a given body area and for a certain length of time. So class 1 would be things like clobetasol or fluocinolone. Class 2 are things like betamethasone. Class 3 are things like triamcinolone. Class 4 or 5 would be hydrocortisone valerate and nesinide. And then class 6 would be like hydrocortisone. So it's good to know these because, again, you're going to want to use the right strength of steroid. Because of the problems with side effects, you want to avoid the class 1s and 2s for any length of time short of a very short exposure on the face, for instance, or in the intertriginous areas like the axilla or the groin. Otherwise, if more potent steroids are used, you can get into problems with atrophic changes as well as ocular changes with topical use around the eyes. And so it's really important to be aware of these side effects that can happen. And there are quite a number of them, and it's important to make sure, for instance, that one is not treating a tinea with a steroid, which may make the situation much worse. So in general, class 1 or 2 steroids on the trunk and extremities, use sparingly on the face, just a few days on specific areas, and then taper to class 3 or lower on the trunk within a few weeks for significant disease. And then you can retreat with high potency for new lesions or new flares, and then taper to class 6 on face or non-steroidal cream or ointment in the case of more facial lesions. And so again, the idea is to start more potent, but then rapidly decrease so you can minimize side effects. The evidence for antimalarial use in cutaneous lupus is actually pretty good, and we know that 55 to 60% of patients will respond to hydroxychloroquine. But that leaves a lot of patients that we then need to go on to other therapies. We've often used quinacrine, and we found in a small study that 66% of patients who were refractory to hydroxychloroquine did respond to quinacrine. And we also know that we can switch from hydroxychloroquine to chloroquine in patients who either don't tolerate hydroxychloroquine or where it's not been effective. And the issue with chloroquine, of course, is more eye toxicity, and so one has to be very careful to monitor eyes more than you would normally with hydroxychloroquine. And this is showing in our study of patients entered into a database that at time 0, they were started on quinacrine, and you can see in the responders defined as a 4-point improvement in the CLASI activity that there was a very rapid improvement in the activity score in the skin. And even in the non-responders on the right, you can see there was a trend down. And so quinacrine has been really helpful, and we were interested to understand more about that. So our studies have actually shown that hydroxychloroquine and quinacrine can inhibit interferon alpha production from stimulated peripheral blood mononuclear cells when they're stimulated with a single strand of RNA. But in the case of TNF, it's actually only quinacrine that can, on the right, inhibit the production of cytokine, and hydroxychloroquine has no effect on stimulated PBMCs in terms of TNF production. Interestingly, we've been able to show that there are more myeloid DCs in the skin in patients who require quinacrine for treatment versus hydroxychloroquine responders. Both of them have PDCs, but it's really the myeloid DCs that are a differentiating factor. And what we've also been able to show is that TNF the signature is higher in those requiring quinacrine, again, suggesting that there are cells that can stimulate it to make more TNF. And in the ones who respond to hydroxychloroquine, you can see a higher type 1 interferon signature in the skin prior to treatment, and this would suggest that, again, the PDCs are making a lot of type 1 interferons that are driving the signature of interferon in the skin. So there really are differences between antimalarials and Unfortunately, quinacrine is now on import alert, and there are shortages that have developed. So what do we do for our patients who don't respond to hydroxychloroquine? Well, we can use chloroquine, where there's more eye toxicity than with hydroxychloroquine, and the recommendations have been less than 2.3 mg per kilo ideal body weight, or less than 3.5 milligrams actual body weight if they're not underweight. Retinoids work for some patients, but are not more effective than antimalarials, and they have more side effects, and thus are difficult to use long term. This would include drugs like Accutane or Soriatane. Oral steroids are not normally used except while waiting for the onset of action of another therapy if the primary target is the skin. Obviously, SLE patients may be on steroids for some period of time because they need them for their systemic disease, but if they mainly have skin, we would really encourage use of some of the therapies we're talking about now that are not steroids. And then dapsone can be used for bullous LE or for adjunctive therapy to antimalarials. The reason for this is that they're more neutrophils as opposed to lymphocytes in bullous lupus, and dapsone blocks neutrophil migration and is effective for neutrophilic blistering conditions. And it is a safer alternative than systemic steroids for mild bullous lupus patients who don't have a lot of serious SLE at the time of their bullous lupus. There have been also reports of rituximab helping refractory patients, and so this can also be a help. So what are the other alternatives that are not immunomodulatory but more immunosuppressing, such as immunosuppressive drugs? We have thalidomide, which has issues with teratogenicity and a peripheral neuropathy, which limit its use. And then we have biologics, which are costly and not very available for patients with just mainly skin manifestations, and are really more in development at the current time. So in terms of immunosuppressives, we mainly talk about methotrexate, mycophenolate mofetil, mycophenolic acid, azathioprine, tacrolimus, and cyclophosphamide. So clearly cyclophosphamide may be used for renal disease, and if so, then that will frequently treat the skin. But for skin-predominant patients, we often will use the other drugs that are on the list, although we find azathioprine is probably less effective than methotrexate or mycophenolate or mycophenolic acid. This is just showing a trial with mycophenolate mofetil, and what you can see here is on the left prior to treatment and on the right after treatment, and here again before on the upper panel and on the bottom panel after. So certainly in this particular patient, the mycophenolate mofetil was very helpful. The CLASI score was determined and found a decrease in many, but not all patients, suggesting that in some patients this use of immunosuppressives such as mycophenolate mofetil can be helpful. We did an open-label prospective study of 13 patients that did not respond or tolerate antimalarials, and half of these patients responded when treated with immunosuppressives, leaving another half who did not. And methotrexate and mycophenolate mofetil are more effective than azathioprine in terms of clinical impression, but there's not that much data about this. So this is showing that if you can affect the activity in the skin, meaning again a 4-point drop in the CLASI, then you get improvement in the emotional quality of life score of the patient. So on the left are responders to a immunosuppressive, and you're going to see that the quality of life improves. On the right, they did not have any change in their activity score, and you can see there was no change in their quality of life. So again, emphasizing that if you can improve activity, you can improve quality of life. Thalidomide has been used for many, many years, and there was one study in Spain suggesting 80 to 90% efficacy, beginning very quickly after 2 weeks, with full effect in 4 to 8 weeks. The highest responders were SCLE and DLE, with over 90% of patients responding, and there was no difference in response in localized versus generalized discoid lupus. So for severe patients, this can provide a really good alternative. There is a high rate of relapse if the disease is stopped, although frequently the relapse rate is less in subacute cutaneous lupus. And these patients do respond to retreatment, although often require maintenance, although sometimes at a very low dose, maybe once a week or twice a week. The side effects include drowsiness, paresthesias, neuropathy, reversible amenorrhea, stroke, and teratogenicity. So we try to avoid using this in patients, for instance, who have a history of stroke or antiphospholipid antibodies. And this is the kind of result that you can see before and after thalidomide. There are analogs that are up to 50,000 times more active than thalidomide and potentially less neurotoxic, but they have complex mechanisms that have been studied and seem to be helpful in patients who have cutaneous lupus. This is an example from a lenalidomide open label trial that we did, and you can see at baseline week 0 on the left upper panel, and then improvement in erythema scale on the right-hand side, and you're left with damage. And then this was accompanied by improvement in the infiltrate that you can see correspondingly below. In this trial, 4 out of 5 patients improved with a greater than 4-point improvement in the CLASI. 1 of 5 did not improve, and 1 of 4 with skin improvement had new onset proteinuria and arthralgias that went along with activated PDCs in the peripheral blood. And so this was a cautionary note. However, there was a study subsequently that showed improvement with lenalidomide in 15 patients with an 86% complete response rate. And the point here is that the improvement can be very, very quick. This is a teratogen, so it requires very careful monitoring, but perhaps less peripheral neuropathy that we see with thalidomide, and highly effective in selected patients with severe disease. And it's also been used for even in pediatric patients who have had very severe disease. There are other new therapies to talk about, including CC220, where this is a derivative of lenalidomide, which is now being studied. And here, it's Ikaros and Aiolos zinc finger transcription factors that are involved in immune cell development. And these transcription factors are overexpressed in PBMCs of patients with SLE, and there are polymorphisms in these genes that are associated with an increased risk of developing SLE. CC220 reduces the zinc finger protein levels in B cells, T cells, and monocytes, and was screened to be more potent than thalidomide or lenalidomide. And in a phase 2 trial, looking at patients who had moderate severe skin disease, what you can appreciate is in red, the placebo group did not change, but the other doses of the treatments with CC220, the patients had rather significant, really on average about a 10-point drop in their activity score. And so this is a very encouraging result, and there's a larger phase 2 trial that's now ongoing. So what other biologics? So let's talk about ustekinumab. And here the rationale is that IL-12 is essential for Th1 cell development and cytotoxic T cell activation and function. IL-23 drives the expansion and survival of pathogenic Th17 cells, which promote inflammation in tissues. And IL-12 and the IL-23, IL-17 axis have been implicated in the pathogenesis of SLE. Ustekinumab blocks IL-12/23. There was a phase 2 SLE study, and the primary endpoint was at 24 weeks, and then the patients were crossed over into active therapy. And this study was published in The Lancet last year and showed an improvement in terms of the percentage of patients accomplishing a primary endpoint of an improvement in the SRI-4 of 4 points. And you can see that 60% of patients accomplished this relative to 31% of the placebo patients, and this was significant. And so, interestingly, the CLASI activity score also decreased with treatment, and that was seen in 64% of patients relative to 30%. So again, suggesting that both skin and systemic findings were improved in patients treated with ustekinumab, and a larger study is ongoing. So what about B cells and their role? So belimumab was studied, and there was not a skin-specific outcome looked at here, but there clearly was improvement based on the SLEDAI in terms of rash and arthritis, and led to the approval in a post-hoc study of 2 phase 2 trials where the data was combined. So here you can see that there was some improvement, although again it would be good to look at more randomized trials related to skin. Rituximab has a more mixed review, and in one study of 82 SLE patients who got rituximab, 32 had significant skin disease either before or after treatment, and 39% of the patients with baseline skin disease had a beneficial skin response at 6 months, but they all had acute cutaneous lupus. And if you look at the patients with either DLE or SCLE, they did not improve. And so this again emphasizes the importance of collecting data on subsets in order to know about the responses that are seen in the systemic trials. There was clinical response associated with a negative anti-RMP and anti-ROS serology, and flares of SCLE and CCLE occurred in 12 patients who had no skin disease or acute cutaneous lupus at baseline, suggesting that actually treatment with rituximab may actually aggravate the skin and should not be really something we think about automatically for patients who have refractory DLE or SCLE. We know there's an interferon signature in the PBMCs from patients with cutaneous lupus as well as SLE. And here you can see that the patients have, with SLE and DLE, have an interferon score in their blood, similar to what is seen in lupus, but different than what we see in tumor lupus and in normal controls. We know there's a positive correlation between the interferon score and the CLASI activity score. So it looks like the higher the interferon score, there's a correlation with the amount of skin activity. So that brings me to talking about anti-type 1 interferon, and one example of this is anifrolumab. And anifrolumab had a positive clinical trial in the phase 2 trial, and it's an antibody against the type 1 interferon receptor. And what you get is inhibition of IFNOR and the inability of a multitude of type 1 interferons to stimulate production of type 1 interferon. Or activation of the receptor. So anifrolumab blocks the receptor, and what you can see here is the placebo in gray clearly has a much lower kind of effect in terms of the improvement that was seen in skin relative to the two dosing groups where 60% or so of patients were responders. And you can see an example of day 1 and day 281 where the patient responded to the treatment. And then in terms of neutralization, you can see that this is working very well with neutralization of a 21 gene type 1 interferon signature. And you can see when they stop the drug, in blue, at day 365, the interferon signature starts to increase. So JAK inhibitors also are another way to think about inhibiting interferon. And there's been a baricitinib trial as well as a topical JAK inhibitor trial for discoid lupus. So baricitinib is a JAK1 and JAK2 inhibitor, and in a double-blind placebo-controlled phase 2 trial of 314 patients, it was found that there was relatively low disease activity with a mean CLASI 4 to 5 and no particular improvement in skin in treated versus placebo, but we would need to examine more severe skin disease to make a real comment about this. But there was improvement in the musculoskeletal and arthritis, and since the composite endpoint was skin and or joint, the joint improvement drove the positive outcome in this phase 2 trial, and they're going on now to a phase 3 trial. We did a study with a topical JAK inhibition for DLE, and you can see here that this is a relatively ineffective treatment, but it may have to do with either the particular preparation or how it gets into the skin. So this is not really a commentary on whether or not this approach might work. And then PDCs are another source, since we know that plasmacytoid dendritic cells are a part of cutaneous lupus. And there's a drug called BIB59, which basically has effects on PDCs in terms of their ability to activate and produce type 1 interferons. And there's also another a potential approach with depletion of PDCs, which is going to be done in the very near future. So there is an antibody against BDCA2, which causes internalization of this receptor on the PDC. And basically, we know that it inhibits the expression of type 1 interferon by human plasmacytoid dendritic cells. And it does this through an Fc-dependent and Fc-independent fashion, leading to inhibition of pro-inflammatory chemokines, IL-6 and TNF as pro-inflammatory cytokines, and also a variety of type 1 and type 3 interferons. So this is really actually an interesting approach to treatment. And what was done in a small trial that's been published in JCI is that you can see that 6 of the 8 patients were responders based on their CLASI. And what this is showing is that the amount of type 1 interferon read out as a mix A, which is a type 1 interferon upregulated protein. You can see, for instance, on the left-hand panel, the upper and lower panel, under mix A histology, that there's lots of purple at day -1, which goes away at week 4 and corresponds to improvement in the CLASI activity score. There were 2 patients where nothing happened, and you can see on the right-hand panel at the end of the mix A histology that, in fact, there is no change in the mix A, and therefore this was a non-responder. So this approach seems to have worked in quite a number of patients, and there's an ongoing trial in both SLE and CLE, and it will be interesting to see how that works. So biologics in cutaneous lupus have promise. It's clearly a heterogeneous disease. There is a need for new therapeutics when patients are resistant to conventional immunosuppressive agents, and it's unlikely that one agent will successfully treat all all disease manifestations in all patients. This is a very exciting time for lupus innovation. So in summary, in a patient, beyond sunscreen, sun avoidance, and stopping smoking, you want to think about using topicals, whether it be steroids or non-steroidal T-cell inhibitors. Hydroxychloroquine would be also a drug of choice, although sometimes one would need to switch to chloroquine if hydroxychloroquine is not working. Immunosuppressives are the next line, and for individual patients, dapsone or retinoids may be helpful. In very severe refractory patients, thalidomide or lenalidomide can be very helpful, and we wait to hear about the results of the trial that I described to you. And there are many new therapies in the future that may work in skin. Thank you very much.